Assalamu alaikum. Hello from the US again. My name is Dr. Eman Attaya. I wish I could be in Moscow with you guys, and one day, inshallah, I'll be able to give these lectures in Egypt. Today, we're going to talk about the radiological review of pneumonias. Let me just get here. So our goals are to understand which imaging modalities we should use when we want to evaluate a pneumonia. And we want to recognize the different radiographic signs associated with pneumonia and recognize the specific patterns that we see with the different types of pneumonia and develop a differential diagnosis for pneumonia and be aware of the complications of pneumonia. So what is the definition of pneumonia? It's an infection of the lower respiratory tract by various organisms, which results basically in consolidation of the lung. And it's actually the single largest cause of death in children worldwide. In the US, for adults, pneumonia is the most common cause of hospital admissions, other than women giving birth. And methods of spread include upper respiratory tract, aspiration through the blood, or exogenous routes such as an endotracheal tube. And so what happens is we have infection of the lung, you get an inflammatory response, the alveoli and the bronchioles fill with a proteinaceous fluid such as neutrophils and RBCs, and then you get the consolidation of the lung. Imaging modality. So chest x-ray is the imaging modality of choice in the initial evaluation of patients with suspected pneumonia. And according to the American Thoracic Society, we want to get a posterior, anterior, and a lateral radiograph if you can. Sometimes the patients are not able to do that. And in that case, you can just get an AP radiograph. And the chest radiograph establishes the presence of pneumonia. It determines its extent and location, assesses treatment and response. So after you've treated them for pneumonia, just get a chest x-ray to see if it's resolved. And it can diagnose complications such as pleural effusion and pneumothorax. When you want to get a CAT scan, so CAT scan is seldom required in the initial evaluation of patients with pneumonia. And we should get a CAT scan in patients with a clinical suspicion of infection with a normal or non-specific radiographic finding. So their chest x-ray is normal, but you have a high clinical suspicion that they have a pneumonia. In that case, it's good to get a CT. And of course, it allows a better depiction of the pattern and distribution of pneumonia. Of course, it has a greater sensitivity than chest x-ray, and it's useful in the assessment of suspected complications or a suspicion of an underlying neoplasm. And you want to get a CT if your patient has recurrent persistent pulmonary opacities that are not resolving after treatment. Ultrasound, so the main role of ultrasound is to assess for pleural effusion and empyema and to guide for aspiration and drainage. However, a lot of studies are now showing that lung ultrasound has a higher sensitivity with a similar specificity compared to chest radiography for pneumonia and for other conditions such as pleural effusion, pneumothorax, and pulmonary edema. So as radiologists, we don't normally use lung ultrasound to evaluate the lung parenchyma, but I know that other clinicians who cover the ICU are using ultrasound to diagnose certain entities. So its advantages are that it can be performed in the ER or it can be performed at bedside in the ER and ICU. It's radiation free, it's portable, and it's real-time imaging, so you get to see everything in real time. So I just added some photos that I've taken to add some color to the presentation. Radiographic signs of infection. So imaging signs of thoracic infection, they can be useful to help us give a specific diagnosis and help narrow the differential diagnosis. And keep in mind, these signs can also be seen with non-infectious causes, and we'll go over briefly some of these. Air bronchogram sign, I'm sure you guys all know this. We can see it on chest x-ray and CT, but air-filled bronchi become visible when they're surrounded by consolidated lung parenchyma. So if you can see, maybe this is very faint here, but you can see this lucencies, these lucencies, branching lucencies, those are air bronchograms, and it's better depicted on CT here. The silhouette sign is something that we see on chest x-ray. This is a basic sign that we should all know from medical school, but you get a loss of normal lung soft tissue interface caused by a mechanism that replaces air. So again, this is not specific for pneumonia. You can also have this with atelectasis, but For example, let's say you have a middle lobe pneumonia, it will obscure the right heart border. So here, here's a normal right heart border, and now that we have a pneumonia, we can't see that right heart border. A lower lobe pneumonia will obscure the hemidiaphragms. Do you see how there's an opacity right here, and we can't see that medial aspect of that left hemidiaphragm very well? Here's an example of a lingular pneumonia. It's obscuring the left heart border, so we don't see this left heart border. Here's a normal left heart border, so the silhouette sign. Bulging fissure sign, again, this is something we see on chest x-ray. It's expansile lobar consolidation causing fissural bulging, and we see that with Klebsiella and pneumococcal pneumonia. So you see, like the displacement of a fissure, the bulging of the fissures. Think about a Klebsiella or a pneumococcal pneumonia. Tree and bud sign is something we only see on CT. What happens here is the small airways or terminal bronchioles become visible when they get filled with mucus and pus, and it resembles a budding tree with a nodular Y and V branching opacities. And you can see this with bacterial, fungal, or parasitic or viral infections. So here's an example of a tree and bud. You see these little nodular densities that look like blossoms on a tree. So we call that a tree and bud sign. Air fluid sign, you can see that with lung abscess or empyema on a CT or a chest x-ray. We have this cavity, and then we have this air fluid level. So that's the air fluid sign. The finger and glove sign, in that we'll see tubular and branching opacities that appear to emanate from the hyla, and it resembles like gloved fingers. And what that represents are dilated bronchi impacted with mucus. And so keep in mind that we see this sign with allergic bronchopulmonary aspergillosis. So do you see these tubular branching densities that are emanating from the hilum? The miliary pattern, again, we only see that on CT. So you get multiple small pulmonary nodules. Small, when we say small, they're less than 3 millimeter, and they're randomly distributed throughout the lungs. And that's usually seen with TB, with hematogenous dissemination of disease, but you can also see it with other infections. So let's talk about bacterial pneumonia. So the different patterns of bacterial pneumonia are lobar bronchopneumonia, aspiration, or round. In lobar pneumonia, we have homogeneous airspace consolidation involving adjacent segments of lobe, and the alveolar spaces fill with an inflammatory exudate with little or no tissue damage. And so the consolidation will begin in the periphery of the lung, and then it spreads centrally. And with this type of pneumonia, you usually get air bronchograms. So the infection doesn't involve the bronchi. So you get, the bronchi are spared, so you get air bronchograms. And keep in mind, this is usually unilateral, and the most common cause of a lobar pneumonia is the Streptococcus pneumonia. So if you get a chest x-ray and you see a lobar pneumonia, keep in mind, okay, without getting a sputum culture, you could say this is probably Streptococcus pneumonia. Here's an example of a lobar pneumonia in the left upper lobe. You can see an area of consolidation here. And this is the CT correlate, area of consolidation with air bronchograms, as we mentioned earlier. Bronchopneumonia, this looks different than a lobar pneumonia, okay? So it's actually patchy consolidation involving single or multiple lobes. And the infection begins in the epithelium and spreads to adjacent alveoli. And the consolidation starts in the peribronchial region and extends to involve lobules and segments of lung. And with bronchopneumonia, you'll have airspace nodules, which you don't with lobar. You can get bronchial wall thickening, and cavitation is common. Air bronchograms are rare, so you won't see air bronchograms with the bronchopneumonia. You can also see bronchopneumonia with the fungi and viruses. So here's an example of bronchopneumonia. We have patchy consolidation of multiple lobes of the lung. Here's a CT picture of it. Again, patchy consolidation. We have little nodules here and involving more than one lobe. Aspiration pneumonia, risk factors, alcoholism, poor oral hygiene, reduced consciousness, esophageal or swallowing disorders. And this has aspiration pneumonia is basically a bronchopneumonia pattern, patchy or confluent consolidation in the dependent portions of the lungs. And usually the right lung is involved more than the left because we know the anatomy of the right main stem bronchus is more vertical than the left. So aspirate tends to fall in the more vertical portion of the lung. In upright patients, we'll see it in the basal segments of the lower lobes. If they're lying down, then we'll see it in the posterior segments of the upper lobes and the superior segments of the lower lobes. Here's an example of aspiration pneumonia. Do you see how the right lower lobe is involved with more aspiration than the left lower lobe? We also have a right pleural effusion. Round pneumonia, it's most common in children, so you won't really see a round pneumonia in adults. If you see like a rounded mass, then be suspicious of something else in adults. The majority are solitary and occur in the superior segments of the lower lobes. Air bronchograms are present, and streptococcus is the most common etiology. So round pneumonia is kind of like a lobar pneumonia. Here's a child, and we have a rounded pneumonia in the left lower lobe, and just see how round it looks here. So moving on to atypical pneumonia, I'm only going to talk about a few, mainly mycoplasma here. So mycoplasma is the most common cause of community-acquired pneumonia in young adults, so 5 to 20-year-olds. And it has a different pattern, right? So the inflammation is limited to the pulmonary interstitium and the interlobular septa, and it has a reticulonodular or a patchy opacity pattern, especially in the perihilar lungs. And you can get atelectasis, and it usually involves the lower lobes. So again, it's reticulonodular and patchy opacities in the perihilar lungs. This is atypical pneumonia. So let me see if I can. I can't zoom. Okay, so patchy opacities kind of in the perihilar regions here and involving the lower lobes. This is an example of mycoplasma pneumonia. Fungal pneumonia, again, I'll only talk about aspergillosis here. Aspergillosis is normally found in immunocompromised patients, and you have different spectra of the disease. So you can get an aspergilloma, which is a mass within a cavity, and it creates this air crescent sign. I'll show you a picture of that here in a second. Allergic bronchopulmonary aspergillosis, we see that in asthmatics and people with cystic fibrosis. And I showed you that earlier. It's the finger and glove sign. So you get bronchial dilatation with mucus impaction and airway invasive aspergillosis. And that you'll see tree and bud opacities. And the histoplasmosis, those are usually nodules with or without calcifications. That's common here in the Southwest US. So a lot of scans that we read, they all have, these calcified granulomas or nodules. Here's an example of an aspergilloma. It's a mass within a cavity, and so it creates this air crescent sign. Again, here's an example of finger and glove. So it looks like fingers, and this is an example of ABPA. Here's the CT of it. You can see that these bronchi are dilated and filled with debris. Viral pneumonia. So viral pneumonia looks different than bacterial pneumonia in certain ways, and we'll talk about here. So on chest X-ray, the viral pneumonia can be normal, or you can see unilateral or patchy bilateral areas of consolidation, nodular opacities, bronchial wall thickening, and pleural effusions. So remember, lobar consolidation is uncommon with a viral pneumonia. And on CT scan, we can see these different patterns. So parenchymal attenuation disturbances such as mosaic attenuation of the lungs, ground glass opacities and consolidation, nodules, micronodules, tree and bud opacities. And remember this, nodules that are less than 10 millimeter likely represent viral infection. You can get interlobular septal thickening, bronchial and bronchiolar wall thickening. Here's an example of mosaic attenuation of the lungs. Basically what this is alternating areas of lower and higher attenuation. The areas of higher attenuation are areas of air trapping. So once the bronchioles get inflamed, the air goes in inspiration, and then it gets trapped. It can't go back out on expiration because the bronchioles are not as pliable. And so you get these areas of retained air, air trapping. So that is common with a viral pneumonia. Ground glass opacities, again, these are just, areas of, opacification, but they're not quite consolidation. So we call them ground glass opacities. And here's an example of ground glass opacities. nodules. You can see these tiny nodules throughout the lungs that you get with viral infection. Bronchial wall thickening. Do you see how the wall of the bronchus looks the bronchi look a little bit thick? So again, you see that with viral pneumonia. Moving on to COVID pneumonia, I gave a lecture about this in October, so I don't want to go into too much detail, but it's good to review quickly. So with COVID pneumonia, you're going to see bilateral patchy and or confluent band-like ground glass opacities or consolidations in a peripheral and mid to lower lung zone. Okay. So example here, patchy band-like ground glass opacities in mainly peripheral, mid to lower lung zones. And they've classified the CT imaging features of COVID pneumonia as a typical appearance, indeterminate appearance, and atypical appearance. And so the typical appearances, like we mentioned earlier, peripheral bilateral ground glass opacities, multifocal, things like that. So here's the typical appearance. Again, patchy, ground glass, subpleural opacities, multifocal. Here's a more a rounded morphology of the COVID pneumonia. Keep in mind that there is a temporal evolution with COVID pneumonia. So in the early stage, you could have a normal radiograph or normal CT, or you have mainly ground glass opacities, and that's 0 to 5 days. Progressive stage, you get more ground glass opacities and crazy paving. The peak stage is progressive consolidation, that's 9 to 13 days. And now that we're a year out from the peak of COVID pneumonia, a lot of the CTs that we're reading are this late stage where you see a lot of fibrosis. So you're seeing parenchymal bands, architectural distortion, traction bronchiectasis. So I'm seeing a lot of that now. This is just the temporal evolution. So early on, and then later you get, early on it's ground glass opacities, later you get more consolidation. And then here's an example of what we're seeing now. A lot of is this kind of architectural distortion with parenchymal bands. Moving on to mycobacterial pneumonia, briefly we'll divide that into a primary TB and post-primary TB. So primary TB is disease that develops after initial exposure, and what you'll see with that is hilar or mediastinal lymphadenopathy with low density centers, patchy consolidation, pleural effusion, and cavitation is rare with primary TB. Remember that 15% of radiographs can be normal with initial exposure of TB. Post-primary TB is disease that results from reactivation of a previous focus of TB or reinfection. And so that involves mainly the apical and posterior segments of the upper lobes and superior segments of the lower lobes. You can get patchy consolidation, poorly defined nodules, and linear opacities. And cavitation is more common in post-primary TB. The miliary pattern that we talked about earlier, you can see that with both primary and post-primary. Here's an example of primary TB. We have an area of consolidation in the right lower lobe. Do you see how this hilum looks full? There's a lymphadenopathy here. So here's a CT. We have an area of consolidation. And this is the lymphadenopathy with low density centers. So you can see a lot of mediastinal lymphadenopathy, and it's low attenuation of the lymphadenopathy. Post-primary TB, so like we said, cavitation is more common and involves the apical segments of the lungs, and we have all these nodules associated with it. Differential diagnosis, we need to keep in mind that sometimes atelectasis can be confused with pneumonia, pulmonary edema, hemorrhage, neoplasm, atelectasis and pneumonia. So as I mentioned earlier, both of these can have air bronchograms, but we want to look for signs of volume loss that will point us more towards atelectasis, such as bronchovascular crowding, fissural displacement, mediastinal shift, diaphragmatic elevation. And on a contrast CT, atelectasis will more commonly enhance with a Hounsfield units of greater than 85 Hounsfield units compared to pneumonia. So if you were to measure the density of the area of consolidation, if it's greater than 85 Hounsfield units, it's more likely to represent an area of atelectasis than pneumonia. Lung cancer versus pneumonia sometimes can be tricky. You'll have an opacity, you're not sure, is this, you know, a lobar pneumonia? Is it a mass? So look for these other signs, such as spiculated margins that you'll see with lung cancer. The vessel sign is a sign where, you know, they describe a feeding vessel feeding the mass. I'm not sure how specific that is. Pleural thickening and pleural retraction, usually don't get that with pneumonia. You get it with a lung cancer. And there was an article talking about how short, tortuous, and stenotic air bronchograms are more likely associated with a lung cancer. So just keep those ancillary findings in mind. Complications, lung abscess, empyema, septicemia, necrosis, nematoceles, and scarring. And sorry, I went through that really quickly, but thank you so much for your attention, and I hope to see you soon.